Yes, it's
Okay.
on YouTube. It's on YouTube.
Okay. Thank you. Okay, hi everybody. Welcome to Congenital Heart Academy. We are very happy to have all of you with us today, and I'm sure this is going to be an amazing session to all of you. So for you keep track of what we are doing, please follow us on social media and subscribe to our YouTube channel. We are very happy to have more than 7,000 colleagues with us on YouTube channel. So we are going to have this meeting there, and all the other meetings that Congenital Heart Academy had done so far are all there, so you can watch again and you can share with your team. And if you feel that this meeting of today from Dr. Meryl Cohen is interesting and help you on your practice, please share with your colleagues after the meeting, please. So as you can see, April is full of activities from Congenital Heart Academy, and you all are invited to join us. And every Friday we have Dr. Anderson with his morphological series. Now Dr. Diane Spicer is joining him to show some anatomical pieces, and Dr. Adrian sometimes shows some pieces as well. So this has been a very interesting interactive webinar. So please join us every Friday. So the next one, we are going to talk about common arterial trunk. And next Monday, we are going to be very happy to have Dr. Silverman talking about tetralogy of Fallot on his amazing image morphological series. So please join us and then share with your team, because I'm sure this is going to be very good. And we are continuing with Dr. Gilvernovsky series. We are not going to talk about tetralogy of Fallot on April 27. Actually, we are going to continue his TGA talk. So in March, we talked about the transitional circulation, and now we are going to talk on the 27th of April about the early post-op care. Please join us. And then in the end of month, we are going to have our fetal cardiology meeting talking about fetal cardiac intervention. This is going to be a very night on April the 29th. Please join us. And now with you, our dear Dr. Mary Cohen. She's going to talk to you about echo imaging of coronary artery anomalies. Thank you all for participating. Dr. Norman Silverman is with us today as a panelist to answer your questions in the end of the session. So please type all of your questions on the Q&A chat box during this meeting, so Dr. Mary and Dr. Silverman are going to be able to answer all of your questions, and this is going to make the discussion even more rich. Thank you very much, guys, for joining us, and thank you, Meryl, for being with us once more.
Thank you, Grace. I will share my screen now. Are you able to see it?
Yes, very good.
Okay. Good afternoon or evening, everyone. I'm going to talk to you today about imaging of anomalies of the coronary arteries. And I'm going to present a variety of different lesions where we can use multimodality imaging to assess these issues. So echocardiography of coronary arteries is relatively new compared to us looking at other structures of the heart. When we started doing echocardiograms in the early 80s, late 70s and early 80s, we really did not pay much attention to the coronary arteries at that time. But of course, with the arterial switch operation and other lesions where coronary arteries are impacted, and of course with diagnosis of ALCAPA and anomalous aortic origin, it became clear that echo needed to be a screening tool to help us identify these problems. So it's been a relatively standard part of the routine pediatric echocardiograms since the 90s. But it's also important to recognize the limitations of echocardiography with regard to coronary arteries. They're very small structures, And ultrasound may not really be able to distinguish certain important features. Sometimes we really cannot see the origins of the coronary arteries. And it is very difficult for us to distinguish between aortic wall and the orifice, which makes it troubling for us to make a clear-cut determination of an intramural course by echocardiography. And it's also important to point out that a still frame image can be extremely misleading with regard to the coronary arteries, because you can make a coronary artery really very easily look like it's coming off the aorta when it's not. And so color Doppler really aids us in our diagnosis. And then I would also suggest that we need to be humble in our approach with echocardiography and understand its limitations. And when other things are pointing to a coronary artery problem, but we are convinced that the coronaries are normal, we should consider other modalities. And so my caveat, and maybe not everybody agrees with me about this, is that coronary arteries anomalies can be ruled in by echocardiography, but they cannot be completely ruled out. And just to review the normal coronaries on echocardiogram, here's the pulmonary artery, here's the aorta, and you see the right coronary artery diving towards the right and is an anterior structure, and the left coronary artery, you can see here the left main dividing into the LAD and the left circumflex. This is something we routinely do in the parasternal short axis view on routine echocardiograms, and here you see it on CT scan pretty clearly. So we're going to cover a few lesions today. We're going to cover anomalous coronary artery off the pulmonary artery and coronary artery atresia. We'll also cover anomalous aortic origin of the coronary artery, briefly coronary artery fistulae, and then I'm only going to cover two of these because others are covered when you discuss those lesions, but I'll briefly talk about anomalies of the coronaries and transposition of the great arteries, and you can also put double outlet ventricle into that, as well as tetralogy of Fallot. This is a guideline we published about a year ago in the Journal of American Society of Echocardiography, which is a multimodality guideline for congenital coronary artery anomalies. And Grace is going to include that in the email when you do the survey and evaluation of this talk. So you will have the ability to have access and a copy of this PDF if you wish. And most of what I'm talking about will be in that guideline. And I just bring your attention to this comparison of techniques table from that guideline, just to show you that echocardiography has some limitations, particularly looking at distal course branching of the coronary arteries, whether there's an intracoronary abnormality, and also if there's an intramural course. And so it has some limitations that some of the other modalities do not have, but of course does not require ionizing radiation, can be done quite readily. So we use it as a first line in most circumstances. So we'll start with ALCAPA, anomalous left coronary artery from the pulmonary artery. And here you see two specimens, one showing you the left coronary artery arising from the pulmonary artery and the consequences of that, which are get ischemia, particularly of the endocardium, which is quite vulnerable to ischemia. And this is known as bland white garland. It was first reported as a syndrome in 1933. And as many of you know, it's not that there is blue blood getting into the myocardium that's the problem. The problem is that as the pulmonary vascular resistance drops, after the first few weeks of life, you get reversal of flow. So you get steal from the myocardium into the pulmonary artery. And this causes ischemia of the left ventricle, which can result in this endocardiofibroelastosis you see here. Because the papillary muscles have end arteries and do not allow for collateralization, you will often get dysfunction of the mitral valve, mitral regurgitation, and you get overall LV dilation and dysfunction. This is usually an isolated disease, but you can see it in association with congenital heart disease. When you do, it's even more complicated to make the diagnosis. Excuse me. And I just wanted to point out that there is an infant presentation of this disease, which typically occurs about 6 to 8 weeks of age as the pulmonary vascular resistance drops. You get symptoms of heart failure and failure to thrive. The heart enlarges. You get a murmur of mitral regurgitation typically. And one of the most important features in the history when you speak to parents of children who have this is that they say their child gets very colicky while they're eating, which is likely a form of chest pain or angina because of their increased metabolic demands during sucking and swallowing. So that's unique because colic typically occurs after baby eats. So when you hear that, you should sort of target that this may be a problem. Some people make it through the neonatal period without a recognition of ALCAPA, and often they'll be picked up because they have a continuous heart murmur because they've developed good collateralization of flow from their left to the right coronary artery. Sometimes they'll be asymptomatic, but they may get angina with exertion. And there have been some case reports of sudden death in this population. And so here is one of the significant features of this disease. You'll see a massively dilated left ventricle, very poorly contractile. You'll really see it in any view, subcostal, apical, parasternal. And the dysfunction is pretty profound and global. You'll often have that mitral regurgitation as a result of dysfunction of the papillary muscles. You can see this sort of sclerosing or echo brightness of the endocardium as well as the papillary muscles, the endocardiofibroelastosis. And so this is evidence of ischemia. And if you see an echo like this in a child who is about 2 to 4 months of age, this is a coronary problem until proven otherwise. So even if you can convince yourself by echo that the coronary arteries are normal, you need to continue your investigation because this is very likely to be a coronary problem. Often we get lucky and we will notice other things about this patient, and particularly in the parasternal view, you will see flow from that abnormal coronary artery entering the pulmonary artery. So you see that color jet. Here you see it on the leftward side. Here you see it basically sitting on top of the pulmonary artery, and here coming from the right. So you can see it can come from any location. So you really have to scan the entire pulmonary artery, including the branches, because it can be as high as a right or left pulmonary artery branch. And unfortunately, it's not always obvious, particularly in a baby who's very sick with a heart rate of 180 or 200. It can be challenging sometimes to see the coronary artery entering the pulmonary artery. And so another thing we look for is this hallmark feature of ALCAPA, which we typically see in the parasternal view, which is reversal of the color flow. Here you see the coronary artery actually arising anteriorly from the pulmonary artery, and you can see the LAD and the circ, and the blood, the color should be red as the blood is going towards the myocardium, but you can see it's blue coming backwards. So this is the hallmark feature and really helps us to recognize this disease pretty readily by echocardiography. There can be some other findings, additional findings you can have in this situation, such as the collateralization. What sometimes a sonographer will do is they'll do some sweeps with color and they'll say, oh, there's multiple ventricular septal defects in this patient. And in fact, this is all coronary collateral flow. And so these are connections between the left and the right coronary artery. And as a result of that collateralization, the right coronary artery, to compensate, will often become enlarged. And so these are some of the common other features we see in association with ALCAPA. And so it's really easy to be fooled. Here you can really suggest that the left coronary artery is arising from the aorta in this patient. And I'm just going to play this clip because I told you not to use still frames. And you could still very much convince yourself that this coronary artery is arising from the aorta. And the reason why we make this error is because the aortic wall is quite thin and can be beyond the resolution of echo. And the coronary artery usually passes right by the aorta to go to its more distal normal pathway. So you must use moving clips and color Doppler to confirm this diagnosis. And again, I will say, if everything else points to ALCAPA, consider another modality to prove the coronary artery origin. A more rare diagnosis is ALCAPA, when the right coronary artery is arising from the pulmonary artery. This diagnosis usually has a later presentation. It's because it's the right ventricle at lower pressure. We don't often see the ischemia that we see with the left coronary artery. They will present typically with a continuous heart murmur, and they may or may not have symptoms with exertion. And they usually have a significant collateral burden, which you can see here. You can see this in this parasternal short axis view, a very dilated left coronary artery, which is taking on the burden. And you can see the right coronary artery making its way into the proximal portion of the main pulmonary artery in this parasternal long axis view. Ventricular dysfunction is uncommon, but there have been some reports of sudden death in this population too. And I'll briefly touch upon left coronary artery atresia. This is a beautiful path specimen courtesy of Diane Spicer, which shows the sinuses of the aortic valve. Here you see in the enlarged right coronary artery, and that the left coronary artery becomes atretic before it enters the aorta. This is known as Calm syndrome, congenital atresia of the left main, and there are few reported cases. We actually have had a series of them at our institution for unknown reasons. Patient has no left coronary ostium. The left coronary artery typically ends blindly, and again, you get that collateral flow from the right coronary artery, and it mimics ALCAPA. This looks very much like ALCAPA, and it usually requires additional imaging to confirm, because in these cases, you will not see retrograde flow of a coronary going into the pulmonary artery. And so here's an example of a patient who has left coronary artery atresia. Again, left coronary artery looks relatively normal, like it's attaching to the aorta there. But when you look very closely, you get the suggestion of retrograde color flow in the LAD. Again, this is extremely subtle, but look at the sweep you see on the right-hand side. And again, the left ventricle is massively dilated. There's echo brightness of the endocardium. And so it really mimics ALCAPA. And so you need to look further if you see a heart that looks like this. So you won't have that coronary flow in the pulmonary artery is the difference. Surgical intervention for ALCAPA is typically reimplantation of the coronary artery into the aorta. But in coronaries that are somewhat distant from the aorta, you can perform a Takeuchi procedure, which is shown here on the right-hand side in the parasternal short axis view. You can see this pathway here that has been a window, if you will, that's been made in the pulmonary artery to allow the blood from the aorta to make its way into the coronary artery. And so if the coronary is too small for reimplantation or it's far away, those are the indications for this procedure. The important things postoperatively to look for, in addition to flow getting into the coronary artery and recovery of the LV function, is to make sure that there's no supravalvular pulmonary stenosis because of this baffle in the pulmonary artery, which can occur. So the take-home message with regard to anomalous coronary from the pulmonary artery is if you see a left ventricle that looks like this, a coronary problem is highly likely. And don't let this ever reassure you when the coronary artery really does appear to be arising from the aorta. And a reversal of flow in the left coronary artery is the key to diagnosis. So you may not always see that origin of the pulmonary artery, and if you have a high index of suspicion, use other modalities to make the definitive diagnosis. I know I keep harping on this, but I do because if you have been doing this long enough, you will have seen an error made in this diagnosis. And it is critical to make this diagnosis because it is a surgical solution to it. So these patients have a form of cardiomyopathy that is potentially reversible by surgery, in contrast to other patients who have cardiomyopathy. So it's very important to make the diagnosis as soon as you can when you recognize that there's an issue. Anomalous aortic origin of the coronary artery is our next topic. And again, you see a beautiful path specimen from our paper of a coronary, a left coronary passing between the aorta and the aortic and pulmonary valves. And it's a relatively uncommon finding, but the reason why we pay so much attention to it is because it is associated with sudden death in use. Now, some variations are what we consider, and I put in quotations, benign. We actually don't know that they're benign. We just haven't seen cases of sudden death associated with these particular variants. And then there are clearly known high-risk variations. When the coronary artery crosses between the aorta and the pulmonary artery, if it takes an intramural course, an intramural means that it is coursing within the wall of the aorta. Interarterial means that it is just between the two great vessels, but not traveling in the wall of the aorta. And if we see a patient who the surgeon recognizes as having eccentric or slit-like orifice, then that orifice can be closed off potentially during exercise. These are a variety of spectrum of variations of anomalous aortic origin of the coronary artery. Again, this is in the paper, so you can review it later. And so with regard to echoing these findings, echo, again, is a screening tool for this diagnosis. And so it is the modality of choice when there are cardiac symptoms such as chest pain or palpitations or any suspicion in that situation. It is relatively good at detecting the abnormal origin of the coronary artery and can also see, of course, the abnormal course, as you see on your right, on the right-hand side of your screen, where you see the coronary sort of passing abnormally between the two great arteries. But we are not able to distinguish often if there are two origins or one. You can see here, I would have trouble telling you if there's only one or two orifices of this coronary artery. And we really don't have a good idea by echocardiography of whether a patient has an intramural or an interarterial course. And how bad are we? Well, there was a wonderful paper done by the CHSS looking at anomalous aortic origin of the coronary arteries, what the echo report from the institution showed compared to the surgical report. And you can see that the association was pretty lousy with regard to intramural course, intraconal course, interarterial course. We were able to identify that the patient had an anomalous coronary and which origin it came from, but these other things we were pretty bad at in our own echo labs. And then when you actually used a core lab who specifically were looking for these findings on echo with a number of experts, it still wasn't very good. And in fact, for intramural course, the kappa was only 0.36. So I would not take this to say that we are not good at our job. What I would take it to say is that echocardiography cannot make this distinction. So here are some of the variations with unknown risk. Again, some people call this benign, but we really just don't know if that's true or not. And that includes most commonly circumflex artery from the right coronary artery. You'll see this quite often in a routine echo that you do on a normal patient. If both coronary arteries are arising from a single cusp or single ostium, as you see here, and here the left is coursing anterior to the pulmonary artery, and anomalous coronary artery that does not course between the two great arteries, and then intraconal coronary artery, which I'll show you an example of, is when the coronary artery dives into the conal septum. So here's an example of circumflex artery from the right coronary artery. And this is often where you'll pick it up. You'll see in either a subxiphoid view or in an apical view, you'll see the coronary passing just behind the aorta. And you see this beautiful specimen that Diane Spicer has dissected. And then this is an example of intraconal, extremely rare actually. What happens is it's a single right coronary, and the left coronary getting over to where it needs to go dives into the conal septum. Here are the great arteries superimposed so you can see them. And here you see the coronary diving into the conal septum. Here's the pulmonary artery, and you can see it in this high parasternal view as well. And then in this subxiphoid view, you can see a coronary artery under the pulmonary artery. And this is considered the hammock sign. You see sort of the coronary swinging right in front of the pulmonary artery, and you can see it here in this CT scan as well. And then there are, of course, the variations with known risk of sudden death. And that includes coronaries that cross between the aorta and the pulmonary artery, including anomalous left coronary artery from the right sinus. And this is what we consider the highest risk because it's the left coronary that would become compromised. And then anomalous right coronary from the left sinus. This is much more common, fortunately, than anomalous left coronary, but much lower risk of sudden death in this population. And in fact, most surgeons will fix an anomalous left coronary artery once the diagnosis is made. Anomalous right coronary artery, there's some controversy still remaining about whether those need to be intervened on or not. If the coronary has an abnormal acute angle of takeoff, that puts the patient at high risk, and if the orifice is slit-like, and if the vessel runs parallel to the aorta, and if it crosses a commissure. These are all risk factors that we look for. And again, an intramural versus an interarterial course. Most of these coronary arteries will have some intramural course, but not all. And so why are we worried about these? Because it's the second most common cause of sudden death in young athletes, just behind hypertrophic cardiomyopathy. And here is an unfortunate example from our cardiac registry. This was a 14-year-old girl about a number of years ago who collapsed after she was performing in a race at school. And you can see the circular right coronary artery here, and you can see the slit-like left coronary artery here of the anomalous left coronary artery. And you can see why she had sudden death, which is that she had an ischemic event that likely led to arrhythmia and her demise, unfortunately. So what are the mechanisms of ischemia? Of course, we don't know for sure, but because this sudden death is highly associated with exercise or physical activity, it's believed that as the aorta dilates, the coronary artery becomes flattened, and potentially the eccentric orifice may close off. If there's an osteal ridge, or a ridge of tissue within the coronary, that may obstruct flow during exercise. And being between an aorta and a pulmonary artery that are enlarged with exercise can potentially act as a vice in the interarterial course. So here's what an anomalous coronary looks like in the normal state. Here's the normal left coronary artery. Here's an anomalous right. You can see that eccentric orifice. You can see the back wall of the coronary when you look through the orifice. And you can see that if the aorta and the pulmonary artery dilate, you can see the multiple mechanisms by which a patient might shut off flow to that coronary artery. So these findings are quite difficult to determine by echo and are better determined by CT and MR potentially. But here is an echocardiogram of anomalous left coronary from the right sinus. You can see the right coronary artery arising normally here. And then you see the left coronary artery between the aorta and the pulmonary artery. And this is one of the prominent features by echo that we look for. There's the left. And that is this persistent color signal that we see between the aorta and the pulmonary artery. So in any patient who's getting a routine echocardiogram, part of our routine is to put the color sector between the aorta and the pulmonary artery at the level of the coronary arteries, and to lower your scale to look for this signal. And that can help us detect this abnormality. You can see that you can be fooled. Here, if you just left it at this, you might think that this left coronary artery has a normal origin. I will tell you that I think it's very challenging for us to tell if there's a single or two orifices of these coronary arteries. And I also cannot tell you from these echoes. I can tell you that there's an interarterial course, of course, but I cannot tell you if it is intramural. Here's anomalous right coronary from the left sinus. You can see here the trajectory of this coronary artery, and you could surmise that there is an eccentric orifice in this patient to make its way over, and you could see that highlighted here in the echo and mirrored in this CT scan. Again, can we tell if it's intramural? I would say we cannot. And so how do we tell if it's intramural versus interarterial? Well, by CT scan, for example, when you can look at the entire course of the coronary artery, and if you see that it remains a circle through the entire course, we're suspicious that that means it's interarterial. If you see it develop this sort of eccentric elliptical shape, as you see down here, then we're very suspicious that it's intramural. And so here in this scan on the right, you see the coronary artery flatten and then become circular again. So that portion that was flattened is likely the intramural portion that you see. And we now have some exquisite imaging from CT scan, which really beautifully highlights the entire course of coronaries. Here you see that eccentric orifice in the back wall of the aorta. You can see that eccentric pathway of the coronary here in this patient, and again in this wall here. So this really helps us recognize this diagnosis. What do we do for anomalous aortic origin? Typically an unroofing procedure is done. So the intramural segment is cut from within the aorta, creating a neo-ostium from the left sinus of Valsalva. And we can, on postoperative imaging, see now that there is a orifice here where the coronary had come from way over here. It's now arising from a different location with good flow into it. So that's the typical surgery that's done. And this MRI shows you the new ostium of the right coronary artery in a patient who's had this surgery. So it's circular in appearance. Briefly, we'll touch about on coronary cameral fistulae. Here's just a nice path specimen from Professor Anderson. The affected coronary artery is typically quite enlarged, so it's usually quite easy for us to detect. 60% of them of these fistulae are from the right coronary artery, and it usually enters a right-sided structure, right atrium, right ventricle, or the pulmonary artery, though it can enter left-sided structures, and it can have single or multiple entry sites. If they're large, they can cause a significant left-to-right shunt, though typically they're asymptomatic and present with a continuous murmur if they're of significant size. And here's an apical four-chamber view where you see this increased color signal suggesting that there is a fistulous connection somewhere. And the highlighted feature is dilation of that coronary artery. And just to show you how big they can get, this is a large fistula off the aorta, a fairly complicated one as it makes its connection, and the rest of the coronary artery looks completely normal. And then what about coronary arteries in congenital heart disease? An abnormal course of a coronary artery can impact surgical repair. So specifically in transposition and or double outlet right ventricle, if you're performing an arterial switch, the coronary pattern can impact translocation of the coronary arteries and outcome. And in tetralogy of Fallot, the coronary artery, you can apply this to truncus to some degree too. The coronary artery can cross the right ventricular outflow tract, and in the case of tetralogy, it can impact the ability to do a transannular patch. And later on, when we're thinking about putting pulmonary valves in the cath lab, if there's a coronary crossing the outflow tract, it can cause ischemia when you try to put a pulmonary valve replacement in by a transcatheter approach. And you've seen this when I've given the transposition talk, but There are a number of variants of coronary arteries in transposition. Usual, which is that the left is coming from the left-facing sinus and the right from the right-facing sinus. The sinus is facing the pulmonary artery. It happens in about 2/3 of patients. Circumflex from the right is the next most common, which happens in about 10 to 15% of patients. In our institution, it's more prevalent than that for some reason. And then you can have single left or single right coronary artery. You can have quite funky inverted coronaries where the left coronary is coming from the right-facing sinus and the right coronary is coming from the left-facing sinus, or variations on that. And then, of course, the one we always worry about, which is the intramural, that when the coronary artery passes between the aorta and the pulmonary artery. And there are some helpful hints. So these are two subcostal views in a sweep. This shows you why complete sweeps falling off the heart on both sides enables you to see everything. So if you see a coronary artery crossing posterior to the pulmonary artery, as you see here in this subxiphoid view, you can also see it in apical views. It's one of three things. It's either a circumflex from the right, that's the most common, but it also can be a single right coronary artery, and this is the whole left coronary artery passing behind the pulmonary artery, or it can be inverted, a left coronary artery. Again, left coronary coming from the right-facing sinus. If you have a coronary artery crossing anterior to the aorta, again, this is a sweep where we're going all the way at the end of the heart, passing up towards the aorta, and you can see the coronary just here, wrapping around the anterior portion of the aorta. Again, this is seen well in subxiphoid and high parasternal views, and this is either going to be a single left coronary artery or an inverted right coronary artery. And of course, if you see the coronary crossing between the great arteries, which we typically see best in the high parasternal view, then it's an interarterial intramural course. And here is the usual imaging view we use to see the coronary arteries in transposition. It's a high parasternal view with some angulation to the right and left to visualize both orifices. And here are just some examples of variants in transposition. This is the most common, a circumflex from the right. You can see the aorta here. You can see the right coronary artery here, and then the circumflex making its way around the pulmonary artery. And you can see in this apical four-chamber view, as you sweep up, you can see the coronary passing behind the pulmonary artery. It looks very similar to the circumflex from the right in the normal patient who has normally aligned great arteries. This is an example of a patient with single left coronary artery. So you can see from the anterior cusp, you can see the right coronary artery about to wrap around the aorta, the LAD and the circ. And here you see it in color. See it sort of tri-branching there. And then here's an example of an inverted coronary in a high parasternal view where you see the entire left coronary artery passing in these side-by-side great vessels behind the PA and branching into the LAD and the circ. And you can see that the right coronary artery here is making its way over anteriorly. And of course, the dreaded intramural coronary artery we can also suspect by echocardiography. Here you see an example of the intramural course it's taking between the aorta and the pulmonary artery. And here in this high parasternal view, you see this echo signal between the PA and the aorta. You see it in this example over here as well in this high parasternal view. And then there are a variety of variants in tetralogy as well. Most commonly, we worry about the left anterior descending coronary artery coming off the right coronary artery, and in doing so, passes anterior to the right ventricular outflow tract, and thus a transannular patch cannot be performed in these patients. So often these patients have to undergo an RV to PA conduit, and there are other variants as well. It is hard for us by echocardiography to distinguish if this coronary is a conal branch or a dual LAD or just the LAD. but certainly when we see a coronary crossing, there is concern. So in conclusion, there's a spectrum of congenital coronary artery anomalies, and we need to recognize the potential variations. Some of them are very impactful on outcome, and echo is a really good screening tool for these lesions, but additional modalities may be required for full understanding, and it can certainly impact outcome of our surgical interventions. Thank you very much for your attention, and I will stop sharing my screen.
Thank you, Meryl. It was very, very good. I'm not, I'm not good in echo at all, but it was very good to learn more and to understand how it's important, all the views that you have to be able to rule out anomalies. I think for me, as a clinician, was the biggest learning point. And I'd like to ask Dr. Norman Silverman to make his comments as usual. And guys, please type your questions on the Q&A chat box so we can discuss better on all of these anomalies. You are muted, Norman.
I'm not muted anymore.
No, you're not. You're good.
I can just say that I think Meryl did a spectacular job on covering all of the anomalies. It seems to me philosophically that there are three issues here. Number one, that because of the ability that we now have to look at CT scanning particularly and MRI, that echo is relegated to become a screening test for these coronary anomalies. And I think that's the message that has to come through for this.
Mm-hmm.
I mean, I don't have any disagreements with you, Meryl, but I do think that I would extend the pattern of a dilated cardiomyopathy to up to the age of 2 or 3 years of age.
Mm-hmm.
But I don't think that, the first couple of months is okay. The issue about this, of course, is that the longer you wait on these patients, with the worse the prognosis is. And the one thing that you didn't cover is, and you alluded to it, is that if you fix them, they get substantially better.
Yeah.
But to my mind, they cannot get to be well because the papillary muscle fibrosis, which is, I think, the coronary flow is primarily or first to the papillary muscles, very richly endowed. And when they're fibrotic, they will never really work well.
Mm-hmm.
And I think that the strain rate imaging studies that have been done recently have shown that even in a well-repaired anomalous coronary artery, there are problems. Now, I'd like to, if I may, just add another little point, because I think that the one problem that we have is the anomalous origin of the left coronary from the right sinus is an important issue. And I think that, to my mind, echocardiography is a really rather good technique at looking at this, because it shows you the distortion of the coronary arteries. And to that end, I would like to, if I may, just share my screen with you and pull this up for you here. And this is a picture from Gaetano Tien. Gaetano is in Padua. I think he's retired now, but he spent a lot of time looking at coronary anomalies. And I hope you can see this picture well.
Yeah, we can.
And I think this explains a lot about what happens in anomalous coronaries, because
That's so beautiful. It's beautiful.
So what this is here is the aorta with the aortic cusp. Here is the myocardium, the ventricular myocardium. This is the freestanding septopulmonary infundibulum, and here is the pulmonary cusp here. And running in the wall between these two is this intramural coronary artery. And I think that, as this highlights from your beautiful pictures, is that the coronary artery, when you see it coming out of the aorta, changes its caliber. Yep. And it's almost always narrow. And I think this is a great picture from Gaetano to show that instead of having a spherical structure here, you have an elliptical structure. And of course, then any pressure applied from pulmonary artery flow or aortic flow will narrow this even further, and that will cause ischemia. And the ischemia is what sets up the sudden death. Now, also the interesting thing about sudden death is, of course, it can occur at any time in the history of the people that have this anomaly. But frequently, and in my experience, it occurs after exercise.
Right. That's right.
And probably
that young lady I showed you.
Yeah, I've got the same. I mean, and you know, this vessel not only is the orifice oblique, as you showed so beautifully from that MRI, but that when there is an increase in pulmonary blood flow after exercise and a lowering of aortic flow, this can cause pressure on this, and that will cause that to be critical in the production of ischemia and sudden death. I've had one boy with this condition that only got it when he dived into water. He would develop a syncope when he dived into water, and I think that's another one of the issues here. Now, I only have one other issue, Meryl. I know your institution has done a spectacular job, Julie, what's her name, Julie? Brothers, yes. Yeah. You know, has talked about what the therapy is. And I think that maybe one little point is that now that the anomalous origin of the right pulmonary artery from the left sinus is common, and unless there are symptoms, maybe shouldn't be operated on. Maybe you would make a comment on that, and I'll stop sharing my screen.
That is a beautiful specimen you just showed. So it really highlights the disease. Yeah, a couple things. I didn't want to get into the controversy of whether you should or should not intervene on anomalous left coronary. I think that's an entirely different topic. We do a very systematic approach to every patient and then make a decision based on each individual patient. There are institutions that will repair all anomalous right coronary arteries. We are not an institution that does that. Part of the issue that doesn't get spoken about too much is that sometimes you cause damage when you repair these coronary arteries. So patients have been known to get aortic insufficiency in trying to unroof the coronary artery. Julie has a beautiful paper which shows that you can see some ischemia after you do the repair, you know, in some patients, which we've seen on exercise studying and perfusion studies. So it is quite controversial. As far as ALCAPA goes, I totally agree with you. Whenever somebody says to me, you know, a young child has presented with cardiomyopathy and the coronaries look fine by echo, I always say, you better make sure, because I have seen that error made not only in my own institution, but in others. And I think I always say, like, either you haven't made that mistake because you haven't done enough echo, or you've just been lucky.
I recently had two patients where there was an anomalous left coronary artery from the pulmonary artery that worked entirely asymptomatic. Mm-hmm. The first patient came to our institution for closure of a patent ductus. There was no echo done in the institution because an outside echo was available, and the patient had the ductus occluded, and in the recovery room, the SDT waves went into the sky, and then an echo was done, which showed an anomalous coronary artery. So I think that it's a great screening test and should always be done. The second patient was sent to us for repair of an atrial septal defect. And indeed, there was a small patent foramen ovale. The patient also had Alagille syndrome with branch pulmonary stenosis. So the anomalous coronary was entirely asymptomatic. And I think that this is something that we have to really be worried about.
I Absolutely. What you often will see in patients who have congenital heart disease in association with anomalous coronary is, because it can be very tricky in that situation, particularly if the pulmonary artery pressure is high, they'll still have often echo brightness of their papillary muscles. And that will be the hint. So you'll be doing the study, and even if their function is normal and they don't have that much mitral regurgitation, as you said earlier, the papillary muscles are extremely sensitive. And I have seen patients where they're asymptomatic, et cetera, and you see papillary muscle brightness. And that's the clue that something's going on, that you have to investigate further.
Sure. I want to make one other little point, Meryl, two actually. The first is that the physiology of an anomalous coronary artery, the ALCAPA, is really the physiology of a coronary pulmonary fistula,
Right.
a big giant coronary pulmonary fistula.
Right.
And what happens is that there's a steal of the perfusion that occurs largely in diastole from the coronary artery into the pulmonary artery. And that's what sets up the ischemia. So physiologically, you have to think of an anomalous coronary as a coronary pulmonary fistula.
Absolutely.
And one other point that I think is worthwhile making for the participants is, and what I have done always when I look for an anomalous coronary, I take a big picture from a global cardiac view, such as the subcostal coronal cut or an apical four-chamber cut, and I put color on the myocardium, because as you see from the angiograms in this condition, there is perfusion of the coronary artery through the myocardium capillaries.
Mm-hmm.
And I think you can see myocardial flow. In fact, I've even got patients where you can see retrograde flow in the left anterior descending coronary.
Right.
And so I think that color certainly, if you look at the old papers from the pre-Meryl Cohen era, when Meryl was still a fellow, is that Elizabeth Fisher from Chicago wrote a paper where she missed 3 out of 5 anomalous coronaries based on echo. And we actually studied that. And I think it's important to recognize the physics of ultrasound in producing this condition. Because when you recognize something in axial resolution, which is incident to the ultrasound, it's easy to recognize. Lateral resolution is not so easy to recognize. And when you look at things in short axis, you have that. And what we discovered was that there is often dropout that we fail to actually recognize in the aortic root in the lateral area. We don't say anything about it. And of course, the structure that runs next to the aorta, between the aorta and the pulmonary artery, as you saw in the picture I showed you, is the transverse pericardial sinus. And so that there's a space there. And then if you get another dropout into the pulmonary artery, you have an anomalous coronary artery where indeed nothing exists.
Right.
So I think that you have to be aware of the deficiencies of ultrasound in making this diagnosis. So that's really all I wanted to say, so that the participants will think about this when they look at anomalous coronaries with the pulmonary artery. And I think that we're lucky these days, because when in doubt, I think you can do a CT or an MR. I think a CT is a phenomenal test, having had one myself for my own coronaries, which are fortunately normal. I think that it's a test that is over in about 3 or 4 minutes. And I think it provides you with the 3-dimensional view all over. And it's really a remarkable technique, as Dr. Tony Lavacek's pictures showed you. So
yeah,
I think that
exquisite. They really tell the whole story.
Yeah. We are lucky now, because when in doubt, CT or MRI.
Correct.
And that's all I have to say. Thank you.
Thank you, Norman. And we don't have any question on the Q&A chat box. So Mary, if you want to make any last comments, and then we can close up. And please, guys, share this link of the YouTube to your colleagues, because it was a very, very beautiful presentation, Mary. Thank you.
Thank you. as usual, I agree with Norman on almost everything. I do hope the take-home message is that Echo is a wonderful screening tool for coronary anomalies, but you can be fooled by things. And so I just, missing a coronary artery anomaly in a patient can be quite devastating. It's devastating for the family, for the patient, and obviously for the practitioners taking care of the patient. So it's just very important to be humble about the modality that you use and understand that it can't answer everything. And that if you see something that makes you suspicious of a coronary anomaly, continue to pursue that pathway until you're absolutely sure, because that will help prevent any bad outcomes for our patients.
Sure.
Thank you so much for the opportunity.
Sure. I think that medicine is a humbling discipline, because nobody can say that they are perfect. Bob Anderson said that he's changing his name to Nobody because nobody's perfect. So I think that we should remember that besides nobody, everybody has made mistakes.
Oh, that's great. Thanks again, Grace. Thanks, Norman. It was wonderful to see you.
Thank you. Great to see you and to see all of the rest of you. Thanks, Sasha. Hidden Sasha.
Thank you, guys.
Bye-bye. And Grace, happy birthday.
Thank you very much. And to our Muslim colleagues, happy Ramadan. Ramadan starts tomorrow. So wish you a holy month that full of happiness to all of you. Bye-bye, guys.
Bye.
Bye, everyone.